Hi, everybody. Thanks for having me today. It's my pleasure to talk today, and I think a lot of the things that I'm going to review here have some interesting parallels on the talk that we just heard about helping students receive our feedback and grow from it when it's not necessarily attached to a numeric value. Because a lot of that transition can be really difficult from undergraduate to medical school, where getting an A is not necessarily our priority, but becoming an excellent physician is. And so that's kind of going to be an underlying theme today. So I'm Dr. Jake Robson. I'm a pediatric gastroenterologist over at the Children's Hospital. For about 5 years, I've been very involved in teaching the doctoring class to our medical students. This is, what you hope that your physician will learn in medical school, learning how to take a good history, learning how to do a compassionate physical exam, and learning how to think critically with information they receive to make the correct diagnosis. Today I'm going to talk about shifting to competency-based assessment, which is something we've done over the years, and kind of pull the curtain back and give you a little bit of insight about what has gone well and what hasn't gone well in so doing. A couple of my partners in this, Dr. Fix in the back is there, that has been a partner in crime in doing this. Dr. Anderson, who's not here today, but we'll talk about whether or not all of our students are truly above average. Since this is a intraprofessional talk, I want to talk just for a second about the landscape of undergraduate medical education. So this is the 4 years in medical school before you get your MD. When you go to residency, then it becomes graduate medical education. But this is talking about those 4 years in medical school. So in the dark ages, when I was in medical school, well, maybe not that long ago, but we're getting on 20 years. So we were assessed based on our classroom-based knowledge. There was a lot of multiple choice question tests. And this all culminated in an exam score at the end of your first 2 years called Step 1, or USMLE, and this was a very big marker of where you got to go to residency, your score on this test. During your third and fourth year, when you were actually doing clinical work, you also got assessed on this. And it ended up that at the end of 4 years of medical school, not unlike high school and undergraduate college, you ended up with a ranking system. There was a single top student in the class, or a top 10% or a top quartile, that emerged from medical school. And this was a key message to the students that if you wanted to do a prestigious training program, you needed to be at the top. So now, under the leadership of a bunch of really forward-thinking people, Dr. Lamb is in the back, we have undertaken this initiative called Med-Ed-Morphosis. And this is very much on par with other leading medical schools in the country. And what are we doing in this? We're sending students to what are called student-led clinics in their very first weeks of medical school. We're doing a lot of hands-on learning. They are not spending nearly as much time in the classroom. There's hardly any large group lecturing. They are working in small groups, and we really want them to see their peers, their other students, as collaborators, not as competitors. We have this model in our doctoring course where students are divided into what are called learning communities. These are for the whole time in medical school. This group of about 10 or 12 people with 1 or 2 learning community coaches. These are seasoned University of Utah faculty members that help the students from day 1 to the end of their time at medical school really grow and learn by doing. Here's just an example of our core faculty. We have people from all walks of medicine. We have anesthesiologists, we have OBs, we have neurologists, we have pediatricians, we have family med docs. And so these coaches work together to really help the students learn by doing and get where they need to be. I want to introduce this topic, and then we'll circle back to how we changed our assessments. So these coaches are responsible for helping students go into the hospitals to get what are called experiential learning opportunities. With the coach, 1 or 2 students go into the hospital and they do a complete history and physical exam on a hospitalized patient. And they're observed by this trusted core faculty member, this learning community coach, to watch them do this. And then 1 week later, they do a write-up. They write down their information, and then they do an oral presentation to their group and the faculty member. And this is a really formative experience for early students. We're talking about people in their first year of medical school. And we think that this really is intended to foster a growth mindset. Try something. It's known to be hard. It is not going to be perfect the first time. We really want people to try and fail and get feedback. So what we noticed as we were adapting our assessment of this activity was, concurrently, a lot of this went away. So over this last 5 to 10 years, we have essentially stopped ranking students in the first 2 years. USMLE Step 1 is no longer scored. You pass or you fail. And almost all of our students pass. Yes, you still, some schools, not all, but most give honors based on 3rd and 4th year clinical performance. But for the most part, we found that the way that we were assessing students on this early experience was very discordant with what we were saying we were doing and what the national landscape was doing. And so I'll give you an example, let me first say that this is how we've adapted to the new landscape in medical education. So here are our kind of key physician aims for the School of Medicine just put forth this summer. And really, we are focused on this curve, not a ranked curve, not a 90% and above curve. We're trying at the end of their medical school training to get people to a proficient place where they can see patients in the hospital with supervision during residency. So here's how we used to grade this. And what's really interesting is that, we're trying to give students meaningful feedback and trying to help them grow, trying to help them adopt that growth mindset. But look at what we were doing. We were giving them numeric scores. We were saying, 16 points on the history. It's good. It needs minor improvement. As a student, if you took away that number, you would say, okay, I can work with this. But as we were, ranking people and saying, well, you only got an 80% on this, imagine the outcry that we heard for people that were just trying to show up and get their A, right? This is a major cognitive dissonance coming from undergraduate. And look at this, 10 points, fair, needs moderate improvement. These are students that really need to take this feedback and up their game. They were getting a 50% and they were in our office screaming at us, not screaming, but having a spirited discussion with Dr. Fix and I about, I got an F on this? You're telling me I got an F? I tried my buns off on this. How did I get an F, a 50%? We're like, no, just take the feedback. You're going to get better. And then, no, I'm going to be low in the rank. I'm never going to get to my dermatology residency. And so we also noticed that people weren't taking the comments when they were in the 90s. They were like, I got a 90. Why are you even talking to me? This is fine. And so we realized that we needed to adapt this to get into the growth mindset. So we saw this as an innovation opportunity that we really need to focus on expected progression, not on numeric scores. That we needed to provide feedback in digestible chunks that people could take forward. And we really needed to count on our learning community coaches to identify folks that needed remediation and pull them in for that. And we wanted to make sure that students could get full points back if they improved their work so that there wouldn't be concern that they were falling behind in any kind of ranking system. So here's how we adapted this. It's basically the same language of what we're assessing people on, as far as, for example, getting a chief complaint and taking a history of present illness. But instead, we kicked all of the assessment to the learning community coach to say, in my expertise, where is this student in their kind of progression towards end of first year medical school expectations? And we tried our best to set some kind of a standard, which is if you meets expectations in most of these categories, you got 100%. And we expected that our coaches would sort of say, okay, I'm going to think about this as a bell curve. I'll have some of my students, above expectations. I'll have a few below expectations, and most people will be somewhere in the middle. And this really is key that the coaches have their experience with the students, so they should know where students should be at this time in their training. So we thought that the learning community coaches would provide scores on a normal distribution. We thought that they would be pretty judicious with below and above expectations. And we thought that we would get more students who needed remediation because they could always come back and redo it and get their full points. It should be a pretty low stakes thing to say, hey, this was a little below par and I need you to come back and do this. All right, how do we do? What do people think?
Everybody scored 100.
Okay. Yeah. Here we go. Okay, on the write-ups, we had 70% at meets expectations, so a lot were in that big part of the bell curve, but 25% were above expectations or exceptional, and only 5% were below or approaching expectations. So we were not totally expecting this skew, and we saw the same thing in assessment of their oral presentations. When we kind of broke it down further, we noticed that no one was graded at below expectations. We had, roughly 5% of people at approaching expectations, but then we had a ton of the class, even, almost 10%, 5 to 10% of the class graded as exceptional, which is a big chunk, and then a bunch above expectations. So when we broke it down by core faculty assessor, 4 raters were within the normal distribution, but 10 raters had a significant skew, a negative skew, meaning they were kind of prone to giving above expectation scores. So yes, you were right. We did not quite hit the mark on bringing people for remediation. So what does this all mean? What are the takeaways? So I do think that we're onto something here as far as learning community coaches being allowed to say, I know it when I see it, these students are exceptional, or these students, there are these 5 to 10% that were identified for remediation and some extra help. We were thrilled that we were able to shift the focus away from a numeric score, and we were having more honest conversations about what people needed to get better, really focusing on appropriate progression. This was a start of reframing the students' expectations that they're not going to get a numeric score, and that actually being where they should be is a good thing. We're kind of shifting back from that, I need to get a 90 or above. We're trying to say, I'm actually at where I need to be, and now I have these tools to get better. So what didn't go well? This is Dr. Fix's favorite slide, because generationally, a lot of us grew up listening to Prairie Home Companion with our parents. And so we found, some of us, we found that very few students were below average. Everyone in Lake Wobegon is above average. And good looking. This was a recurring theme. We also had this with prior rating systems, and we were concerned that so few were flagged for remediation. And we thought this was kind of a missed opportunity. As we've talked about this with our learning community coaches, some additional kind of thoughts have come to mind on this, which are, we give students a ton of time to do this, to make the write-up and to do the oral presentation. And we've come to see that it's not so much that students are not being caught for remediation when they need it. It's that our students are really hardworking, and we give them 2 weeks to prepare for this. It actually probably is true that the vast majority of them knock it out of the park because they're working so hard on it. And so the rubric is probably right. It's that we're not catching people that are struggling in the moment because they have time to put the work in and deliver a really good product. So what to do next? We've kind of adapted the scale a little bit, and we've done more faculty development and around kind of judicious ratings. we're kind of dropping exceptional. That no one needs to be rated as exceptional on this. So we've made that a little bit simpler. And then we've made a bunch of videos and multiple example write-ups so we can meet with our learning community coaches to try to get this right. So that's my last slide. I just want to kind of close by saying this has been a really fun thing to work on, and I think this is sort of just in time with the direction we're heading in medical education towards focusing on our expectations, taking away the competition, and helping people really focus on getting where they need to be. And that jives quite well with the first talk that we heard, that students can be competitive, they can be opinionated, and they can be very self-focused. And if we help them not go dark on some of those things, we can have these really positive group dynamics and growth experiences. So we're doing this in a lot of different areas now in the School of Medicine. This was an example of one small place we're doing it, but really in lots of ways across the doctoring course, and even in labs and problem-based learning and team-based learning, we're applying these kind of assessment systems. So thank you for having me, and I'm happy to answer questions. Yes?
It has been documented voluminously that in subjective evaluation of the residents in front of, let's say, faculty, most are evaluated based on the interpersonal skills, how nice they are in the presentation, as opposed to their solid clinical knowledge. In your approach, aren't you skewing towards nicer, smiling, confident residents, as opposed to residents with solid clinical knowledge?
Yeah, so I mean that is certainly part of giving oral presentations, right? Is how you are perceived to speak and kind of interact interpersonally. So I mean we have really tried to get all of these aspects that you're assessing on, right? Clinical knowledge, professionalism, interpersonal communication. There's research that shows that they're near impossible to parse out. So that's why we've sort of put all of this in here. This should include both. So it says, are they getting the correct structure? Have they hit the elements of the patient's history, onset, location, duration? So in part, we're trying to bring all of that in. I don't disagree that it's extremely hard to parse out solid foundational knowledge from interpersonal skills, kind of framing it. But I think we're trying to do both. And admittedly, this is our clinical class. So there's not as much focus on, do you know the science? Do you know the kind of something you would get a multiple choice question about? But it's a great point, and it's something that we're really trying hard to get right. And we do have, in addition to this, we have our assessment and plan, where we're saying, are these things reasonable on a differential diagnosis? And that gives our learning community coaches a chance to say, you kind of just made this up without good support. So I do think we're trying. Yeah?
I understand with this, students can choose to resubmit their work for improvement. How many of them actually chose to do that, or did people just say nah, I'm okay with where exceptional?
Yeah, so we have about 120 students. So if you said roughly 5 were flagged for a redo and 4 redid it.
Okay.
So
the middle group, you couldn't choose to redo it, or you could.
Right, no, most of them were not redoing it. It was the students in the lower part. So 80% of those that were flagged for a redo took the opportunity to redo it. One student said, I'm good with this score, that's fine. Yeah.
I was just going to say 2 things. One of the things that struck me is when you say the skew to one way, could be they were accepted to an extremely excellent medical school, and they were already at the top. And you see that with kids that take honors, do the honors course at undergrad and stuff. So they're already there, and so maybe that explains some of it. The other thing I was thinking was the movie Scully, when the guy landed the plane and they took him to court and stuff, and they, at the final scene, if any of you have seen that, they were able to do a simulation where they could have saved the plane and not crashed. And then they asked, the lawyer asked, or he asked, how many of you did that in the first try? And maybe if you had them they get 2 weeks to do that, but in actual
Totally,
setting,
yeah.
they need to do it quickly, and that can make it.
I agree with everything you said, yeah. And that's something we're building in, right, is that we weren't totally expecting these results, and now we realize we have to challenge with time and with pressure a little bit more to help see some divisions, which we're working on. Yeah?
Are your clinical faculty, the people who are the leads in this, are they also teaching in the classroom? I feel like I work in different.
Yeah.
So I end up with a classroom bias about my students.
They don't know the students very well from a classroom setting, like how they're doing on their multiple choice questions, but they do work with them throughout the whole year. So they do have a pretty good sense of the students before this assignment. So certainly, yeah, they know them well. Yeah, they have seen them in different aspects, but not so much like a classroom bias. It's more just a clinical, they've worked with them. Okay, thanks for having me.